Associate Director of the Penn Orphan Disease Center and co-founder and president of the Castleman Disease Collaborative Network. He's a national best-selling author of Chasing My Cure, A Doctor's Race to Turn Hope into Action, and a patient battling idiopathic multicentric Castleman's disease. So you'll hear about the treatment that he devised along with the help of his physician, and we're delighted that he's here with us today to tell us the story. I'll simply say on a personal note, we first met, I think, in 2019. It was at a conference in Washington, D.C. on repurposing of drugs, and this whole theme was just starting to pick up. And I simply want to say what a pleasure it's been to come to know David. His enthusiasm for life, for science, is truly an inspiration to all of us. So welcome.
Well, thank you so much for that warm introduction. I've so enjoyed getting a chance to spend time with both Ficus and also Vigila over the years. First meeting at that FDA meeting in DC, and then spending every week on Zoom with Vigila, going through treatment options for COVID as part of a COVID task force. So I spent a lot of time with both of them and have so enjoyed spending that time with them. So it's really an honor for me to be with all of you today. Today I'll be sharing about this journey going from chasing my cure, try to find a drug to save my life, to now thinking about how do you scale this to many more diseases. These are my disclosures. Today I plan to share really 5 different perspectives. The first is the perspective of a loved one of a cancer patient. This is a picture of my mom and I. Shortly before she passed away almost 20 years ago. She was diagnosed with glioblastoma just before I headed off to college, and her battle with cancer and really watching the way she battled the disease and also watching the way that her physicians took care of her really inspired me to want to go into medicine. So I'll be sharing that perspective. I'm also sharing the perspective of a physician. This is a picture of me as a healthy third-year medical student. I was at Penn hoping to become an oncologist and treat patients in memory of my mom one day. I'm also sharing the perspective of a patient. This is me just a few weeks after the second picture when I was in the ICU fighting for survival. I'll be sharing the perspective of a researcher where I've gotten involved in driving forward the science around hyperinflammatory conditions. And finally, the perspective of an advocate, because I realized that you can do important research and you can publish papers, but without working directly with patients and other physicians and researchers to really drive forward care, then you're really limited in the impact that you can make. So I'll start out with a personalized approach to cytokine storm, personalized medicine, and Castleman's. We'll go beyond Castleman disease and close with some future directions. So I'll start out with a case. This is a 25-year-old male medical student who presented to the emergency department back in 2010. Reporting about 3 weeks of fatigue, weight loss, and what we're describing as these blood moles or cherry hemangiomas, with just about a week of constitutional symptoms and some right upper quadrant pain, no significant past medical history. The physical exam was notable for some palpable lymphadenopathy, some peripheral edema. The labs were really quite benign appearing, maybe elevated creatinine and some borderline cytopenias. What was concerning was the CT scan. So patient was scanned in the emergency department with diffuse lymphadenopathy. And so for previously healthy 25-year-old with diffuse lymphadenopathy and some constitutional symptoms, and particularly the ascites, you can imagine there was a significant concern for lymphoma. I'm sure everyone in this room would be thinking that. Of course, the other things on the differential are going to be, is this some sort of atypical autoimmune condition or maybe some sort of infectious etiology? And so that's exactly what we were thinking. Patient was admitted for workup of lymphoma versus some viral infection versus some autoimmune disease. But there was a really rapid clinical decline in the ICU or requiring transfer to the ICU, gaining 70 pounds of fluid due to really low albumin levels and also renal dysfunction, requiring dialysis 3 times a week. With a sky-high BUN and elevated creatinine due to this really intense inflammatory syndrome. So CRP over 300, just really, really intense inflammation, resulting in acute retinal hemorrhage, causing temporary left eye blindness, transaminitis, really severe anemia and thrombocytopenia requiring daily RBC and platelet transfusions with no bumps in those transfusions. So maybe I'll open to the audience. What's on your differential, and don't use don't use the answer that I may have already given you guys. But and what are the kinds of things that you're thinking about when you see this patient? Now you've gotten consulted into the ICU. What are your thoughts? Anything that you throw out? Any stuff would be on your mind?
Picture of like cytokine release syndrome.
Yes, looks just like cytokine release syndrome. It might be HLH, might be on your radar. Hopefully, Castleman's is on your radar. Of course, we did this really extensive diagnostic workup. Rheumatology came in, and there were a couple of notable positives, such as positive SSA and ANA, but really notable negatives. None of the specific autoantibodies were present, and there was no joint pain. There was no improvement with high-dose corticosteroids. Infectious disease came in and did the full workup and found no evidence of an acute infection, but a historic EBV infection. And then Hemonc came in, and the thing that really stood out was this tumor lysis-like syndrome that occurred upon high-dose steroids. So though there was no symptomatic improvement, there's this really clear tumor lysis-like syndrome requiring respirocase. But there were a number of notable negatives. The bone marrow looked fine. The SPEP and UPEP were normal. There's nothing from flow of peripheral blood that indicated there was lymphoma or leukemia. No hemophagocytosis in the bone marrow. So I hope all of you are thinking right now, well, what about those lymph nodes? I don't see anything in here that there was a biopsy done. So, what's going on with the lymph nodes? And so in this particular case, it took about 11 weeks of critical condition before the lymph node biopsy was done. And part of that was because the patient was so critically ill that there was sort of concern about taking the patient to the OR. And obviously with the really intense thrombocytopenia, there were some reasons to be concerned. But 11 weeks in, patient finally had a lymph node biopsy. And of course, the intention behind the lymph node biopsy was to evaluate for lymphoma. But when that lymph node was sent to pathology, they looked at it, and this is one of the germinal centers over here. And what was really notable to the pathologists is what they're called collapsed in or atrophic germinal centers. So the germinal centers, rather than being plump and filled with B cells, they're really collapsed in on themselves. And the other thing is the hypervascularity. So there's sort of blood vessels tortuous in every direction in this lymph node. Those are features that have been described as part of Castleman disease. So this is a picture of Benjamin Castleman on the right. He described a group of disorders that share a common appearance under the microscope. So that atrophic germinal center, the increased vascularity, is really the hallmark of any form of Castleman disease. We like to break Castleman down into a number of subtypes. So there's patients that have unicentric Castleman, so a single region of enlarged lymph nodes. Those patients are generally cured with surgical excision. And there's what we call multicentric Castleman disease. Now you've got multiple regions of lymph nodes. They all look the same under the microscope as the unicentric patients, but this is a life-threatening condition. So multicentric Castleman disease can be caused by POEM syndrome, or a monoclonal plasma cell population, where it's actually that monoclonal plasma cell population that's producing lots of cytokines and growth factors like VEGF and IL-6 that ignites the cytokine storm that was mentioned earlier. And so it's really this monoclonal plasma cell population driving. On the other end of the spectrum, it can be caused by a virus. Human herpes virus 8, when it replicates uncontrollably, creates a cytokine storm, which again is life-threatening. But then there's a third type of MCD, which we call idiopathic MCD, where there's no evidence of a virus or evidence of a malignancy. We call it idiopathic because we don't know the cause. But there's still a similar cytokine storm. So like you heard earlier, it's really a sepsis-like picture, multi-organ failure, hyperinflammation in the ICU, but again, no evidence of a clear etiology. So that's what we have in this patient. Testing for HHV8 was negative. Testing for monoclonal plasma cells is also negative. So we've got idiopathic multicentric Castleman disease. There was no diagnostic criteria until 2017 for IMCD. Mary Jo in the room was part of that diagnostic criteria development. But we came together and we came up with these criteria. So you need multiple regions of enlarged lymph nodes. You need lymph nodes that have this particular appearance under the microscope. And then you need, and just highlighting what it is. So this is a Castleman's germinal center versus a normal germinal center. You can immediately appreciate that it's really collapsed in, and it's sort of missing all the B cells that are supposed to be in the germinal center. And then the mantle zone, the ring around the germinal center, is expanded in Castleman's versus a normal GC. And then there's all these blood vessels in sort of every direction that you don't see in a typical normal lymph node. So in addition to the histopath, you also need these clinical and laboratory features. And again, these are really just the same features that you see in any sort of systemic inflammatory condition. So low albumin, elevated CRP, renal dysfunction, but in particular, fluid accumulation is really notable in Castleman. So I described earlier in that case, 70 pounds of anasarca. So this is a combination of really leaky capillaries, but also renal dysfunction, then also liver dysfunction causing low albumin levels. Importantly, to make the diagnosis, you need all these things, but you also need to rule out a number of conditions like sepsis, like lymphoma, a number of autoimmune conditions as well, to make that final diagnosis. So IMCD historically has had a similar 5-year overall survival to if you combine all cancers together. So all cancers together has about a 68 5-year overall survival. And MCD, as of 2012, was around a 65% 5-year overall survival. Those numbers are improving. We're now north of 75% 5-year overall survival, probably closer to 80 or 85% now. But it really does sit in this really interesting place where it's not an autoimmune disease, it's not a malignancy, it's not an infectious disease. It's just this hyperinflammatory condition. At least as of now, we don't know where to categorize it. At some point, we will be able to put it into one of these buckets. But the heart of it is really a cytokine storm. So cytokine storm is a way to describe a hyperinflammatory state where you actually get pathology due to the immune response. So your immune response is good in a lot of cases, and you need a healthy, robust immune response for a lot of reasons. But the moment that immune response becomes pathological and starts causing organ dysfunction as a result of an attempt to do good, that's when we start describing something as a cytokine storm. And this is a review that I wrote a few years ago, highlighting what a cytokine storm entails, and also the fact that though many things can trigger a cytokine storm, whether it's CAR-T therapy or whether it's Castleman's or HLH, variety of triggers, but there's a number of common mechanisms, which explains why you can use some of the same drugs across these various cytokine storms, regardless of the etiology. So if we think about the Castleman cytokine storm in particular, back in the 1950s is when Benjamin Castleman described this disease, and over the next 20 or so years, we really started to get a really clear understanding around what does the disease look like clinically and pathologically? What does the lymph node look like clinically? What are the symptoms? But it wasn't until the 90s that Kazuo Yoshizaki discovered that interleukin-6 was a really important cytokine in Castleman disease. And so he uncovered this, but even after Kazuo discovered that IL-6 was important, there's always been the black box around what's causing the elevated IL-6 in the first place. Like, okay, maybe IL-6 is a mediator, but what's really causing this? And that's been very much a black box, though we're starting to uncover it now. What are the signaling pathways, the cell types? What's the etiology? We've hypothesized that maybe there's a pathogen we just haven't discovered yet. Maybe there's a small population of clonal cells that are driving this, or maybe this is really an autoimmune or an autoinflammatory condition. And thus far, we've done quite a bit of work, pathogen hunting, looking for potential pathogens that could be driving it. 3 different orthogonal approaches and 3 independent sample sets have not been able to uncover a pathogen. We're digging into the paraneoplastic hypothesis right now, and have found evidence of autoimmune mechanisms, but are not yet in a position to say this is an autoimmune disease. So even if you don't know what's causing the IL-6 to be elevated, the good news is you can block IL-6. There's a drug called siltuximab blocks IL-6 directly, and tocilizumab blocks the receptor for interleukin-6. And for about a third of patients, you block IL-6, and they just get better. It's pretty incredible. But unfortunately, for about 2/3 of patients, you can block all the IL-6 you want, and patients don't get better. And so that's really challenging when you have I guess a figure like this, where it's like question marks leading to question marks leading to question marks. What do you do to treat a disease where that's literally all you know about the disease? And so we tend to use, and we've historically used, a lot of conventional chemotherapy. If you don't know what part of the immune system to wipe out, if you just nuke the whole immune system, then that tends to work for a lot of people. Of course, bringing with a lot of morbidities. I did want to just share a quick anecdote because I mentioned tocilizumab. It was, I mentioned that interleukin-6 was first discovered to be elevated in Castleman's by a dear friend of mine named Kazuo Yoshizaki. And so Kazuo made this discovery, and then he went on to develop tocilizumab, this drug that blocks the receptor for IL-6 for Castleman's in Japan. And I'd heard from another friend of mine, Makoto, who works with Kazuo, that Kazuo had given tocilizumab to himself as the first patient or the first human to ever receive it to test it out. And when I asked Kazuo, I said, Kazuo, I heard you gave tocilizumab to yourself as the first human. He said, no, I didn't give it to myself. The nurse gave it to me. I said, exactly, Kazuo. So Kazuo was the first human. He discovered IL-6 as the target. He developed tocilizumab, and then he was the first human to ever receive tocilizumab. So back in the 90s, before monoclonal antibodies were widely used, and he didn't die when he gave himself toci, or when the nurse gave him toci. And he went on to study it in Castleman's. It got an approval in Japan for Castleman disease. And then when it was acquired by Roche and brought to the United States, they decided that Castleman's was too small of a market. So they actually studied it in rheumatoid arthritis, where it got an approval, and then JIA. And we all know in cellular immunotherapy that tocilizumab is used to prevent or to treat the cytokine release syndrome that we see. But it all, of course, you guys will hear from this talk, everything always comes back to Castleman disease. But even cellular immunotherapy, which of course was made famous at my home institution, needs to be treated with a Castleman's drug. So we also didn't have treatment guidelines for Castleman's until a few years ago. Again, working with Mary Jo and others, we developed treatment guidelines. What you'll notice is that we bifurcate treatment based on disease severity. So non-severe versus what we call severe cases. It's really who are the patients that you can afford to wait and you have the time to wait to see if IL-6 blockade will work, versus the patients where they're going to die if you wait more than a few days because they're in the ICU. And that's really as simple as it gets. So regardless of whether we call someone severe or non-severe, we do recommend IL-6 blockade up front. Because even in some of the most severe patients who are in the ICU, they can improve rapidly. But in those severe patients, we also recommend daily monitoring to see if that improvement's happening. And if not, then moving right to combination chemotherapy and just getting the disease under control. So many of you all will probably have guessed that I'm that male medical student who presented to the emergency department back in 2010. And that was, me who went through all the stuff I just described. This is a picture of me and my dad in the hospital about 5 months into my hospitalization. And you can see my dad's actually resting his hand on my belly because I've got such a big belly in the picture. And you can see I've lost all of my hair from the chemotherapy. I ended up getting a combination of adriamycin, cytoxin, topicide, Velcade, dexlutamide, Rituxan, those 7 drugs, which really just obliterated my immune system but saved my life. I was so sick that I actually felt better with every dose of adriamycin, cytoxin, and topicide because it was finally starting to control my disease. And so again, I would love to show these pictures because I think it's so important to highlight that the role of the caregiver. My dad never left my side. Right before I left the hospital, about 6 months, I was in the hospital for about 6 months, and just towards the end of that hospitalization, one of my favorite nurses came in and said, "David, I heard you're getting discharged. You must be so excited." I said, "Yeah, I've been hospitalized for almost 6 months. Can't wait to get out of here." And my dad said, "What is this? I've been hospitalized for 6 months. We've been hospitalized for 6 months." And it's true. He literally, never left my side, and he slept in the pull-out chair next to me for all 6 of those months. So I was eventually discharged from the hospital, and you can see that I've got this really big belly from all of the anasarca and ascites. I was getting tapped 3 times a week, and I was on dialysis 3 times a week as well. So that was when I thought I was really, looking and feeling a lot better. And then this is a picture from a few years before. I played college football at Georgetown. I was a quarterback there. And I always say these are the worst before and after pictures of all time. But if we could flip the order, they could be like a great advertisement for like Muscle Milk or Shake Weight or something like that. But unfortunately, the pictures are in the wrong order. I did take a picture every week for the next 8 weeks, and you can see my hair starting to grow back. You can see the fluid starting to go away. Great. And so I was able to, after spending 6 months in the hospital and another about 6 months recovering, I was able to return to medical school at Penn. This time I was on an experimental IL-6 blocker, that drug siltuximab I mentioned that's now approved. It was undergoing clinical trials. I was on that experimental drug. And though it didn't work for me when I was acutely ill, we hoped that maybe it would prevent a relapse. So maybe it just couldn't get the disease under control because I was too sick and that's why I needed chemo, but maybe it would prevent a relapse. And there was some really promising data coming out on the use of siltuximab. So returned to medical school at Penn and was hopeful that all this Castleman stuff was somewhat behind me. I did get involved in the Penn Orphan Disease Center that was started right around that time. But unfortunately, I relapsed while on siltuximab and nearly died now for the fourth time. And what was so difficult about this relapse was that I was on the drug. Like the drug was targeting the thing in the disease. The only thing we knew about the disease. There were no other targets. There were no other promising leads. It was just IL-6, and that didn't work for me. And so that was really, really difficult to get the news that the only drug in development, the only promising lead wasn't working for me. And I went to Little Rock, Arkansas to my doctor there, Dr. Van Ree, who's really the world's expert for Castleman's, and he's an amazing multiple myeloma physician. And he told me, he said, this is it. We've tried everything that's been tried in patients. You receive thalidomide and you've received rituximab and Cytoxan and really siltuximab, all the drugs that could be used for this disease. And we're really out of options. We're going to keep giving you multi-agent chemotherapy when you relapse, but there's really nothing else that we can do. And so after my doctor explained that to me, I turned to my dad and my sisters and my girlfriend at the time who was with me. And I told them that I would dedicate the rest of my life, however long that may be, to trying to find drugs for patients like me. And of course, didn't actually imagine, that we would find anything or that, I would be here with you all this many years later. But I knew I wanted to go out swinging and see what we could find in that time. So I got multi-agent chemotherapy. The 7 chemos saved my life. I spent a month in the ICU, but I got out of it. And when I got back to Penn, I started conducting research in the lab. And the only samples I get my hands on from Castleman's patients were my own samples. I did have IRB approval to work on my own samples and was able to start doing that in the lab. But I knew that it was unlikely that I would be able to make very much progress on my own. What's a third-year med student going to do on their own? And so that's when I started the Castleman Disease Collaborative Network with the goal of bringing together all the right physicians, researchers, and patients and loved ones from all over the world to fight together against this disease. And so some of our early steps were to come up with a prioritized research agenda for what do we need to do, involve the entire community in coming up with that agenda, make sure that Mary Jo Lekowitz is on that scientific advisory board because I knew we needed her so badly, and she thankfully agreed. But it was really to get everyone together and come up with a prioritized list of what should be done. And some of those early priorities were developing diagnostic criteria, developing treatment guidelines, which I've shared we were able to do. But really importantly, there was another aspect of this too, and that was realizing that we didn't have 10 years and $1 billion to develop a new drug from scratch. We knew that if we wanted to make any progress for this disease, especially progress in the short term, we would need to understand molecularly what was occurring in this disease and then try to understand what drugs are already FDA approved that could be repurposed to treat this disease. Again, we didn't have $1 billion, we didn't have 10 years. So what do you do when you don't have those two resources? You need to look for things that are within reach. I'd been treated with thalidomide and Cytoxan and all these drugs that were not made for Castleman disease, and they had helped me at various stages of my disease. So it was clear that, okay, drugs that weren't made for Castleman disease can help Castleman disease. So maybe there's another drug that wasn't made for Castleman's that can help my Castleman disease. And that was really a critical aspect of our journey. As Vic has shared earlier, I wrote a book about my journey called Chasing My Cure. And there's just one quote from the book that I want to highlight, because this was a really important turning point when I went from sort of being this hopeful medical student, assuming that there were doctors around the world working collaboratively to find solutions and that my solution would be delivered on my doorstep, right in time to save my life, to realizing that hope can't be a passive concept. You can't just sort of hope that like the right researcher is going to work with the right people at the right time, deliver the right drug. Hope is a choice and a force. Hoping for something takes more than casting out a wish to the universe and waiting for it to occur. Hope should inspire action. And when it does inspire action in medicine and science, that hope can become a reality beyond your wildest dreams. So where were we back in 2012? Well, there was about $10,000 a year being spent on IMCD research, which is enough to fund a few breakfasts like we had today. There was no NIH funding that had ever been given to IMCD research period. Federal funding had never been spent on IMCD. There were no patients in a registry because there were no registries. There were 2 advocacy organizations, but there was no sort of research infrastructure or plan for how we were going to drive forward the science. They were accepting research proposals and giving out $5,000 grants, again, for, they can pay for breakfast. There were no cell lines, animal models, no biobanks, no registries. The disease was very poorly understood, the cause unknown. There were no diagnostic criteria, there were no treatment guidelines, there were no predictive biomarkers, no blood test to predict whether one drug could work better than another. There were no FDA-approved therapies. There was one drug in development, siltuximab, and siltuximab didn't work for me. So it was it was terrifying to be in the hospital in critical condition. I think it was almost even more terrifying to be out of the hospital and to understand just how poor the state of things were back in 2012. But like I said, the thing that gave me the most hope was realizing that I was alive in that moment because of drugs that weren't made for Castleman disease. And I'd been given drugs that had been repurposed to try to save my life, and they'd worked. They weren't working long-term, and I kept relapsing, but clearly there were drugs out there that could potentially treat Castleman's, whether or not they were made for Castleman disease. So one of the first things we did was to hold a webinar with a bunch of Castleman's patients, and we sort of decided to take the idea of a Castleman warrior and turn it into like an animated person. So we showed this to a bunch of our patients during our first webinar, and a couple of weeks later, they showed up on our Facebook group. So one of our patients had screenshotted the Castleman picture and then got it tattooed on his shoulder. And I always say, if this is not patient engagement, then I don't know what patient engagement is. But the reality is that this just showed that our community was waiting to get behind this. And there are literally hundreds, probably thousands of Castleman warrior tattoos on patients all over the world. And our community was just waiting to be galvanized behind something. And I think this is just one example of that. So Castleman's is a rare disease. It's diagnosed about 5,000 patients each year in the United States. My subtype IMCD occurs in about 1/3 of those patients, so about 1,500 IMCD diagnoses per year in the US. So it's quite rare. Affects individuals of all ages. You can see we've got one child in there who's diagnosed before his first birthday. We can have individuals diagnosed all the way into their 60s. Really unusual in the sense that it can affect individuals of all ages. So first step was get our patient community together. They were excited to go. Second was to build a team. And so I was a medical student at Penn, and then I was a business school student at Wharton. And so I turned to my classmates and told them I have this horrible disease, will you join us? And involve them in everything from establishing diagnostic criteria, treatment guidelines, building this global network of physicians and researchers, organizing meetings, all as volunteers. I mean, literally dozens of people, spending hundreds of hours, maybe thousands of hours collectively supporting this fight as volunteers. Really just amazing. And we do what we call the Castleman Flex in all these pictures. So collectively, we built an amazing network of physicians and researchers around the world. Now over 800 physicians and researchers that are part of our network, really representing every continent except for Antarctica, and a really engaged group of people that both treat Castleman's but also conduct Castleman disease research. Would love to go through all of our studies, but you can just go to cdcn.org/research and get a sort of summary for where things stand with all of our different research studies. And it's really exciting because when we started back in 2012, there was one research study underway doing a GWAS in Castleman's. And now we've got over 20 that are active and closing in on 20 that we've completed over the last 11 years or so. So in the midst of creating the CDCN and beginning to work on criteria and doing research in the lab, I graduated from med school right around the time I got engaged to my girlfriend at the time, Caitlin, and we set a wedding date, May 24th, 2014. I was so hopeful that that my health would stay in check and I would make it to May 24th, 2014. And then I relapsed and I nearly died for the 5th time. What was really tough about this relapse is that I was receiving weekly Dex, thalidomide, and Velcade, and hopeful that combination, VDT, would help to keep it in remission, but it didn't. And so I relapsed even despite VDT. And thankfully, again, I got the same combination of 7 chemos and they worked. but I knew that it was unlikely that I could continue to have relapse after relapse and that I would actually make it to May 24th, 2014. The good news, though, is that I'd been storing blood samples on myself every couple of weeks leading up to that relapse. And so when I got out of the hospital, I was able to go back to the freezer and thaw a bunch of samples. And so first thing I did was a number of cytokine panels where we measured 13 different cytokines in my blood at multiple time points leading up to relapse. And so this particular graph, you can see the gray bar highlights when I was in the hospital. The dotted line is when I was first admitted. And I tracked 13 different cytokines. Basically, all 13 of them were elevated during my disease flare. But what was notable was that two particular cytokines, one SOLR2 receptor, which is a marker of T cell activation, and VEGF, of course, an angiogenesis factor, began to rise in the weeks and the months leading up to it. So that suggested to me that though everything's elevated during flare, maybe these two cytokines are playing some sort of role. And of course, the SOLR2 receptor being a marker of T cell activation, maybe this T cell hyperactivation is playing some sort of role in this condition. So I took out my PBMCs, ran flow cytometry on them and a few other patients, and we were able to confirm that in fact there was increased T cell activation, not just a marker T cell activation, but actually increased activated T cells, both CD4s and CD8s. The next thing that we did was, and this was sort of giving us a picture that maybe T cell activation, VEGF production were playing some sort of pathogenic role in my disease. Next thing we did was perform a large serum proteomic study using the SomaLogic platform. So we measured over 1,000 analytes in a number of different time point blood samples. And what was really interesting is we ran pathway analyses on those serum proteomic results. And regardless of the tool that we used or the sample we used, the PI3 kinase AKT-mTOR signaling pathway continued to be predicted to be enriched. So the proteins that were elevated in my blood are proteins that tend to be elevated when the PI3 kinase AKT-mTOR signaling pathway is engaged and turned on. So this was very interesting to us because mTOR is critical for T cell activation, for VEGF production, and for a number of cytokines to be produced. So the idea that maybe mTOR could be a mediator sort of fit the bill for what we were thinking about with regards to the disease. During my last relapse, I had asked my doctor to cut out one of my lymph nodes. So that way, if I survived, I would have some tissue to work with in the lab. And he did cut out that lymph node. And so now I had tissue to work on to test, was the mTOR signaling pathway actually, in fact, engaged? It was predicted to be engaged from the proteomics, but could we actually determine whether it was turned on? So I started out with a bunch of normal lymph nodes, and brown is positive for mTOR activation. Phospho-6 is a great marker of mTOR activation. You can see in a normal lymph node, the vast majority of cells are negative for mTOR activation, though there certainly are some cells that are brown or positive. And then we stained my lymph node and was just blown away by the tremendous amount of mTOR activation in my lymph node tissue. I didn't have to look under the microscope, right? And you can just see by naked eye, oh my gosh, one of them is brown and all the other ones are blue. So this pathway was very clearly turned on in my case. And so the model we thought about is that maybe mTOR could be playing a critical or central role across all of these processes that we just uncovered in the disease. The reason we were so excited about that is that there are a number of potent mTOR inhibitors that exist. The oldest and most famous one is rapamune, or sirolimus, also called rapamycin, discovered on the island of Rapa Nui over 50 years ago. It was found in the soil of Easter Island because some researchers were looking for some antifungals. They were digging in the soil and discovered this compound. It went on to get FDA approval for kidney transplant rejection. It's a really potent immunosuppressant. And importantly, the way it does that is by inhibiting mTOR being a critical mediator of T cell activation, as we discussed, but also just immune cell communication. And so if you turn off the mTOR signaling pathway, it turns off a really critical communication line between your immune cells, and your immune cells do a lot less bad things. So we had a plausible mechanism, and we were really excited about the possibility of using an mTOR inhibitor. And so I started testing this mTOR inhibitor on myself 117.63 months ago, which if you're doing quick math, it's almost 10 years ago, and have been in remission ever since. The New York Times called this "Doctor Cure Thyself," which I think is a bit of an overstatement. I think it should be doctor helping himself a little bit right now and hopefully for a lot longer. But I don't think that would have fit. But really importantly, during this remission, Caitlin and I made it to our wedding day, May 24th, 2014. As I think about my journey and all the low points, never could have imagined that I would have made it to our wedding date. And then just as importantly, 5 years ago, we had our first child, Amelia. And then almost 2 years ago, on November 5th, we had our son, baby David. And again, just doesn't feel real that I'm here with you guys today and that I got to talk about my sweet little ones. So during this remission, I joined the faculty at Penn and started a center called the Center for Cytokine Storm Treatment and Laboratory. We refer to ourselves endearingly as the Castle. And actually, Reese Williams is one of my former team members. He's here today, a proud member of the Castle. And we have been able to make a tremendous amount of progress for Castleman disease, a number of cytokine storm disorders. As I mentioned earlier, worked with Vigila on a COVID-related project. So I'm sure many of you all are wondering, well, what about mTOR activation across other Castleman's patients? Well, turns out that we found that mTOR signaling is increased really widespread uniformly across Castleman's patients. It's not just me, we see it really uniformly. And it's not just using phospho-S6, but we can use other readouts like phospho-4-EBP1 and phospho-S6 kinase. And regardless of the readout we use, we get this really strong signal that the mTOR pathway is engaged. And then some of you might say, well, maybe mTOR is engaged, but maybe that's just what you find across any disease where there's lymphoproliferation. You know, if immune cells are proliferating, of course, mTOR is going to be activated. So we looked into that, and we found when we looked at a variety of diseases involving large lymph nodes, we found that IMCD had increased mTOR signaling compared to all of them except for one, and that's a disease called autoimmune lymphoproliferative syndrome, or ALPS, which is treated with sirolimus because mTOR is a critical driver of autoimmune lymphoproliferative syndrome. And so we were really interested to see that okay, it's increased even relative to all these lymphadenopathies, except for one other lymphadenopathy where mTOR is a critical mediator. We went on to do further experiments where we actually stim immune cells in our lab with a number of cytokines, and we find that giving an equal dose of IL-6 interferon beta to Castleman immune cells in the dish will result in increased mTOR activation compared to healthy donors. We've seen this repeatedly in the lab. And so this has created this sort of new model of pathogenesis for thinking about the disease, you know, where mTOR is this central mediator. And the first 3 patients we treated, myself included, had a really profound response to sirolimus. We reported this in the Journal of Clinical Investigation, and we're hopeful that this is going to be, you know, the answer for all Castleman's patients. And, you know, we figured it out, it's over. It turns out that it's more complicated than that. We have a clinical trial that's open where it turns out that somewhere around 1/3 of patients we've treated have had a really good response, and unfortunately 2/3 of patients have not responded well. So though we were 3 for 3 to start, it really looks like it's more like a 1/3 response rate across our Castleman's patients. That's despite the fact that all of us have increased mTOR signaling, but we see this in other areas of medicine where you may have the biomarker, you may have the thing that the drug targets, but clearly there's some bypass pathway or some other mechanisms that are involved in at least a portion of our patients. So I'm going to go through this part pretty quickly. Basically, you know, based on these discoveries and the recognition that mTOR inhibition is not effective uniformly, we launched another project we call the SPEED2 study, where we quantified, again, over 1,000 analytes in a bunch of Castleman's patient samples and controls. First thing we did was dimensional reduction, where this is just a Tisney plot. So every single icon or dot on the screen represents a single patient, and the closer the 2 dots are to one another, it means the more proteomically similar those 2 patient samples are. So we use lymphoma and rheumatoid arthritis and HHV positive MCD in our cohort, and we were interested to see that they clustered well together. So the lymphomas clustered, the HHV positive clustered, the RA patients clustered. So that's good. We would expect to see differences proteomically between the various groups. And then the big question was, where's Castleman's going to be, right? You know, is it going to be more like a lymphoma or more like an autoimmune disease, more like an infectious disease? And then we were disappointed to see that it sort of spans the spectrum, right? So you've got, you know, some patients over here where their proteome is almost indistinguishable from Hodgkin lymphoma. And then you got other patients where their proteome is almost indistinguishable from rheumatoid arthritis. And then you've got this sort of whole spectrum. So it's a very heterogeneous disease. Interestingly, we found that the patients, when we did clustering just within IMCD patients, that actually being more proteomically like RA and more proteomically like Hodgkin lymphoma could predict how you would respond to IL-6 blockade. So we found this one group called Cluster 1 that actually is the most similar to Hodgkin lymphoma that responds really well to IL-6 blockade. We were able to identify 7 analytes that could predict with fairly good accuracy before you give someone drug, whether they're likely to respond or not. The next thing we did was start looking for early indicators of response. Those 7 analytes are not clinically available, and it's complicated to set up a 7 analyte panel. So we wanted to see, is there a single biomarker that we could measure before you give someone IL-6 blockade, and then again a few days after you give it to them, to see if there was a change that could predict whether they're likely to go on to respond long-term. And we discovered, in fact, there is one protein out of the over 1,300 proteins we looked at called CXCL13. It's also called B lymphocyte chemoattractant, where if you measure before you give IL-6 blockade, you block IL-6, then measure it again 8 days later, a 17% reduction or greater predicts with very impressive accuracy whether someone will go on to respond long-term to IL-6 blockade. We also use that same proteomic data to look for other potential targets for therapeutics. And so we did gene set enrichment analysis on the proteins that were elevated during flare versus remission. And we found that the IL-6 JAK-STAT signaling pathway was enriched in both responders and non-responders. And we were expecting to find it in responders because people who respond to IL-6 blockade, you'd expect would have an IL-6 signature in their proteome. We were surprised to see an IL-6 JAK-STAT signature, even in people who don't respond to IL-6 blockade, which suggested to us that maybe there are other aspects of that pathway that are engaged. And so maybe it's not so much that you need to block IL-6 in them, but maybe you need to block somewhere else in IL-6 JAK-STAT signaling pathway. And we confirmed, in fact, there is increased STAT3 phosphorylation or activation of this pathway in patients who respond and don't respond. So whether IL-6 is the driver or not, and then we were able to test in the lab, could we abrogate the increased mTOR activation by treating those same cells that I mentioned earlier in a dish with JAK inhibitors? And in fact, we could abrogate that increased mTOR activation. So that got us thinking about JAK inhibition as a potential other therapeutic approach. And so sort of if we zoom out a little bit and think about the maybe more complicated way we think about Castleman's now, IL-6 can lead to increased mTOR activation through JAK1 and JAK2 signaling, as can interferon beta and other cytokines. But then there's also potentially a bypass pathway through STAT3 activation. So maybe blocking IL-6 is not going to work for everyone because there's other cytokines that can signal through this pathway. Maybe blocking mTOR doesn't treat everyone because there's a bypass pathway through STAT3, but maybe choking the disease off sort of at a choke point with JAK1 and JAK2 inhibition with a drug like ruxolitinib would be an effective approach. And so we made this discovery a few years ago. And then right around that time, I get calls daily from doctors with Castleman's patients all over the world. And one of those days I was getting a call from a doctor in Chicago with a young girl named Kyla who had spent about a year hospitalized and could not get out of the hospital no matter what they gave her, chemotherapy, IL-6 blockade, couldn't get her disease under control. And so I told them, I said, well, about 2 weeks ago, we made this discovery. We think JAK inhibition might be an effective approach for this disease. It's never been given before to Castleman's patients, but obviously you're sort of at the end of your road. And so they gave Kyla ruxolitinib as the first patient ever with Castleman's, and she's responded really, really well. She was just in Philly a few weeks ago. I'm doing great on ruxolitinib. We've given it to a number of other patients and just got an R01 to study JAK signaling in Castleman's and to do a clinical trial of a JAK inhibitor. So where are we today in 2023? Well, thankfully, we no longer just have $10,000 a year, and we've raised about $1.8 million of philanthropic funds and invested them really wisely into Castleman's research. That's led to an additional $16 million in funding from the federal government. We're on our third R01 from the federal government, and also funding from pharmaceutical companies and other philanthropic organizations. And then I listed on here the $25 million for other diseases. We've worked really closely with the Chain Zuckerberg Initiative since they were founded about 5 years ago, and they went on sort of a listening tour of the U.S. to understand what organizations were out there that were making a difference in rare disease, and they decided to model their program called RARES 1 after what we've done for Castleman disease. And so I always joke, they've given out $25 million to other rare disease groups to be like the Castleman's Network and to follow our approach. And it's like, man, it'd be nice if they gave some of that money to us. But we have gotten some of that money. But fortunately, a lot of funding has gone to a lot of other rare diseases to model our approach. So we got the first ever NIH funded R01, the first FDA R01, and then also the second NIH R01. We've got over 1,500 patients that are in our registry. We brought together the two existing communities with us. So the three of us joined together into one collaborative network. We've got a unified research infrastructure, a biobank. We've answered questions, a lot still remains. We've got diagnostic criteria. We've got treatment guidelines. We've got predicted biomarkers, whether one drug will work better than another. We've got an FDA approval, siltuximab, and then we've got a few more drugs that are in development, sirolimus, ruxolitinib, and actually adalimumab. So I'm just going to fly through this pretty quickly and just say that we've thought a lot beyond Castleman disease as well. First off, these are all patients that are alive on a drug that wasn't intended for their disease. And so I'm alive because of a drug that wasn't made for my disease. And these are some of the patients that have come to our center and have received a drug that wasn't made for their disease. And they're doing great. They're not supposed to be here, but they're here because we found a drug that was made for another disease and gave it to them. And so I wanted to highlight Michael. He's in the bottom right. Michael was diagnosed with metastatic angiosarcoma in 2016, and he was given first and second line therapy, which didn't work. And he was told, this is it. Metastatic angiosarcoma is horrible cancer. He just had a few months to live. We did something really simple. We looked in PubMed and we found that 3 years earlier, a paper had been published describing increased PD-L1 expression in 3 patients with angiosarcoma. And so we asked the question, has anyone ever been given a PD-1 inhibitor? Again, this is 2016, so this is before PD-1 inhibitors were in the orange juice. And so we has anyone done this? And at that stage, no one had ever given a PD-1 inhibitor. So we stained Michael's tumor for PD-L1, came back blazingly positive. 99% of his tumor cells are positive. I talked to his doctor at an institution that I will not name, but it's somewhere between here and Philadelphia, and it's a very good institution. Anyway, I talked to his doctor there and said, what do you think about treating this patient with pembrolizumab? And he said, pembrolizumab has never been used before in angiosarcoma or any sarcoma. There's no role for it. And even if there was a role for it, it's too expensive. He just, basically says this is it. He just needs to die, basically. And I said, well, you just told him that he's got 3 months to live. Why don't we give it a shot and let him figure out if it's too expensive? So anyway, we got Michael on pembrolizumab as the first patient ever with angiosarcoma, and his metastatic angiosarcoma melted away. He's been doing great for over 7 years. And what I'm really proud of and excited about is that now pembrolizumab is recommended by the NCCN guidelines as a treatment for angiosarcoma. So there were no clinical trials that have been completed. There's 2 that are underway right now, but just based on patients like Michael and then his physician at an oncology center west of here, very famous one as well, began treating a lot of his patients with pembrolizumab. And it just became very clear that a large portion of patients with metastatic angiosarcoma can respond really well. Not everyone, unfortunately, but a large portion do. And we didn't even have to do a clinical trial, and now guidelines have changed, and there are patients all over the world getting pembrolizumab. So I'm sure all of you are asking, how many cures are sitting on the pharmacy shelf for diseases that we just haven't uncovered yet? We know it works for this disease, but what are the other diseases that could benefit from these drugs? And maybe most importantly, how many cures sit on the shelf while data that links them to those diseases hide in plain sight? The data was already there for 3 years. For 3 years, it sat in a journal, and no one had taken action on it. So how can we fix this problem? So I'm just going to frame the problem for a second. That's that there's about 3,000 FDA-approved drugs that are approved for about 3,000 human diseases. Depending on what ontology you use, we typically use the ontology where there's a total of 12,000 human diseases, which means that though medicine has come up with 3,000 drugs for 3,000 diseases, there's still 9,000 diseases without a single approved therapy. But really importantly, many of those 9,000 diseases have known underlying mechanisms that could potentially be susceptible to drugs that already sit on our pharmacy shelf. Unfortunately, 80% of all of our FDA-approved drugs are already generic, and therefore, by definition, there's no R&D that's being done on these old generic drugs to find new diseases for them. So, patients suffer while there are treatments that literally sit right there at the CVS pharmacy. I think there's 3 reasons why this doesn't happen. The first is that there's no financial incentives for companies to find a new use for an old drug when the drug's generic and not profitable. Second is that no one's ever been responsible for making sure the drugs are fully utilized. FDA gives a thumbs up or a thumbs down, depending on what the pharmaceutical company presents to them. But there's never been a bypass pathway to just say, what are the other uses for this? And then third, there's never been a database or a system that centralize information on what drugs look promising for what diseases. And so about a year ago, I launched a nonprofit called Every Cure that's on a mission to unlock every single disease that could be treated with every single FDA drug possible. It was inspired obviously by my own experience and also by a phone call I got on March 31st, 2021. So it's the day before April Fool's Day. And I got this phone call from an unmarked number. So I answer it. And the person on the other end says, I've got President Clinton on the other line. He wants to talk to you. And so, of course, it's the day before April Fool's Day. And so I was like certain it was a joke. And then all of a sudden I hear, David, it's Bill Clinton. And I'm like, oh my gosh. So it really was President Clinton. So he had read my book, Chasing My Cure. And he was really, so first off, we both went to Georgetown, both went to Oxford, both lived in Little Rock, Arkansas. He was a big college football fan. I played college football at Georgetown. So anyway, we connected on a lot of levels, but importantly, he really was taken away by the idea that drugs could be utilized in more ways than they're currently being utilized. That sort of like blew his mind. And so we spoke for about an hour that first time. And at the end of it, he said, what's your dream? What are you trying to do here? And I told him my dream is to develop an organization that systematically does this across all drugs and all diseases. So that way patients don't suffer when there's a treatment on the shelf. And he said, well, if you ever do that, I think you should. And if you do it, then I'd love to support you. And he's become a really great advisor and friend over these years. So what we're doing isn't really repurposing. And I'm just going to quickly go through how it differs from traditional repurposing. Traditional drug repurposing, you start with a disease and you look across all the drugs that are out there and you say, is one of these drugs that exists out there, is it going to potentially help the disease of interest, whether it's Castleman's or COVID or whatever it may be. And then indication expansion, which is done by drug companies, you start with a drug. That drug is approved for some disease, but now you want to see, are there other diseases that can maybe benefit from that drug so we can have a larger market? So that's typically how drug repurposing is done. You either start with a disease or start with a drug. So what we're doing, and we're still trying to come up with the right term for it, so I actually would appreciate feedback from you all, but we're tentatively calling it therapeutic cross-purposing, where rather than starting with one drug or one disease, start with all diseases and all drugs, and you utilize the world's biomedical knowledge to come up with a single score for the likelihood of every drug to treat every disease. So we know there's links between these drugs and those diseases that are approved for them. We know that there's some data supporting these other drug disease links. But then the idea is, can we look across every link of every drug versus every disease and pick out the ones that look most promising? If you don't care what disease it is or what drug it is, you just want to say, what is the most promising opportunity to help people? And I don't care what those people have for disease, then that's what we're doing. So we utilize large biomedical knowledge graphs that have been developed through NCAT's funding, and also integrate in proprietary data from drug companies and data science companies like Elsevier to come up with a single score for every drug versus every disease. So this is a heat map. It's actually our first version of the heat map. So you get a score from 0 to 1 for every drug versus every disease. So in this particular drug disease pair, let's say that's sirolimus for ALPS. It gets a score of 0.93 because there's a lot of data that supports sirolimus for ALPS, for example. But imagine every possibility for every drug versus every disease. We're planning to make the data fully and openly available, probably in the next 6 to 12 months. We use this to identify among every drug versus every disease, what are the promising opportunities to move forward in the lab, and then to take into clinical trials to prove whether the drug works or doesn't work, regardless of whether a drug company is interested or not. We'll just raise the philanthropic dollars to do the trial. And then the idea is that we're most focused on making sure the drug is covered by insurers and that it's accessible to patients. So doctors are aware of it and it's sufficient evidence to make them believe that this drug is really going to help patients. And maybe it'll result in an FDA approval, but that is not the goal. 20% of all prescriptions written by every physician are for off-label use. Drugs are prescribed off-label all the time. It's very difficult to get a generic drug, to get a label change in a generic drug. You actually need the innovator. You need the Pfizers, the Mercks of the world who developed the drug 30 years ago, who don't care about the drug anymore, to actually submit to the FDA, which is basically impossible. So basically 80% of the drugs that can save humans are off the shelf, or off the table for using, to getting a label change. And so label change is just not a requirement for what we're doing. So I'll just quickly mention that we're using these 5 different algorithms to come up with the scores. And one of my favorites is one that Dave Kozlecki discovered or developed at Penn State. So we ran it. This is the all versus all scores that I mentioned. And of course, you can imagine I looked at the Castleman's results the first and was interested to see adalimumab, a TNF inhibitor, number 1, and another TNF inhibitor is number 3. TNF inhibition has never been used in Castleman's before, so that really caught my attention. And right around that time, there was a patient in Vancouver who was very ill, and he had failed to respond to IL-6 blockade and mTOR inhibition and chemo. And so I spoke to his doctor, Luke, and talked about the possibility of TNF inhibitor, and Alan had a really positive response. He's doing well. It's now been about 9 months or so, doing really well on TNF inhibition. So for me, this was really, really exciting. Early days, N equals 1. Who knows? One score out of 36 million, but was really excited to see that. So we've got an awesome team of partners from all over the healthcare system that have joined behind what we're doing with EveryCure, and then great advisors like President Clinton here doing the Castleman Flex, and also been able to get the current administration really interested. This is Jeff Zients, President Biden's chief of staff. He had us to the Oval Office this summer to talk about EveryCure and what we're trying to do. So I'm just going to close with a couple slides to say that we are always looking for collaborators. So we're doing a bunch of spatial omics work, a bunch of single cell work. So if you are interested in collaborating in some way, or you are a graduate student and you're looking to do a postdoc, or interested in rotating, I'm trying to recruit Reese to come spend some time with us back in Philadelphia. Please let me know. We're always looking for really talented people to join us in labs at other institutions to collaborate with. We've got some really exciting hypothesis-driven work, but also some discovery level stuff that's underway. And again, always looking for collaborators. The last study I'll mention is just the space study. So we're doing that same proteomic profiling, but now we can profile over 7,000 analytes using SomaLogic, and we're looking to do that across hundreds of hyperinflammatory conditions. So if any of you all have samples from patients with CRS after cellular immunotherapy, or you have patients with sepsis or COVID or whatever the hyperinflammatory condition may be, let us know. We're looking for collaborators and obviously excited to partner. So if you ever see a Castleman's patient, please email me and encourage them to go to our website and to register, provide blood samples. And then, like I said, we've got a bunch of positions open, postdoc roles that are open, we're recruiting for. So I'm not allowed to directly recruit and take from Emory, but please do let me know if you're interested in the next step after your current role of coming to Philadelphia. So I will close by thanking you guys all for your time today and thanking my amazing team. Thanks so much. Covered a lot in this 55 minutes.
So we're running maybe just a shade late, but we have time for just a couple of questions. There's no grand rounds next week, I'm told, and I was supposed to announce that. So yes, please.
Great talk, inspirational. You mentioned a little bit about Q loss, but could you talk about epigenetic programming, taxi, and also timers in a not compartment that might lead to disturb immune responses that have been picked up by things like Q loss?
Great question. So we haven't touched epigenetics at all. So we haven't done a tax-seq. I can't tell you any data on that in Castleman disease. We need to. We've got some interesting lab data around increased expression of TNF with stimulation that suggests that maybe there's some chromatin remodeling that maybe makes it easier to express TNF. So I think we need to do it. We haven't. So if you or anyone else in this room can help us, we would love to collaborate. In terms of chimerism, that's one of our leading hypotheses. We just I guess I don't know the difference between chimerism and mosaicism, but maybe we can talk about them. We just got data back from Tempest on our first 5 patients. I think there's another 15 or so we should get data back on, where we did deep sequencing of lymph node tissue, and we did pick up somatic mutations. Now the question is, are they shared across patients, and is this, are they pathogenic? But we did get, variant allele frequencies in the range of 10 to 20%, suggesting that at least there's chimerism or mosaicism in the lymph node.
Yes.
Great talk. So we think about your model about the different pathways you could use to be jacked.
Yep.
And but you could also have to do stack.
Yep.
So have you correctly tested this by using a combination of steroids, with just or not that hard? So we'll see it you still have resistance.
It's a great question. We've been very like monotherapy focused. Like our trial, you have to go off siltuximab before you get on to sirolimus. But I think it's a brilliant point, and I think that maybe we actually can salvage some of those patients that are that are falling off and not responding to one by actually keeping them on the other. It's a really great point. We haven't done it. And I think part of it is sort of being concerned about what sort of immunosuppression we're going to be causing if you're blocking multiple things at once. But I think we need to do it. It's a great point.
Sorry. I think to sort of build on Mary's question, you see on Sunday a couple of years ago, there was a draft all these
Yes.
so the concept of Google block really does make a lot of sense if you don't have unbroken distance and doing it something.
Yeah.
So it's a different question if you're resistant to alignments and then come in with something else.
Totally.
Kind of that.
It's a great point. Yeah.
That was my question. My question is really about what Chris gave you after your second remission, which was DVD,
Yeah.
which pathologically, Chris is a myeloma, right? You can write it into that.
Yeah. They love that, right?
But I think the bigger question is the plasma cell really the target? Because we've got a lot of better drugs now.
Yeah.
And BTD to target plasma cells, and none of those hits came up on your listing.
Yeah.
Whether IL-6 is a huge driver in myeloma. These are something else there that we'll have to do.
Yeah, like a Darzalex or something like that, right? And I think it's a great point. Yeah, we're not sure what to make of these plasma cells. So you have increased plasma cells; they're all polyclonal, and yeah, it's a great point. I think we really need to dig into that further.
Yes, great.
Great talk. Is there any evidence that IL-6 that's driving
Yeah, good question. So possibly, I think there's some theoretical data that if that were the case, that maybe blocking the receptor with tocilizumab would be better than blocking the ligand with IL-6 directly. And we haven't seen differential responses. I have to admit, most patients that fail to respond to one, we usually don't treat with the other. But the fewer we have had a failure in one and tried the other, we haven't seen like one work when the other didn't. But maybe so.
Yes.
Okay, so I'm here about the name on mother people start talking about.
How's she doing?
I still
Mary Jo, nice.
And you know, I guess my question is, what is the nearest condition people hold feel confident in using in terms of their experience? And do you think that there's any natural remedies that can be taken
Yeah, these are such a good question. So I think that I'm still optimistic about a role in the right patient for mTOR inhibition, but I'm really excited about JAK inhibition right now. That's sort of more where I'm hopeful around, especially in the really sick patients. We find that the third that respond well to sirolimus tend to be patients where you give them drug when they're not in like a really critical condition. So if you get them before they've gotten really sick, whereas JAK inhibition, we've given to people really, really sick and we've been able to get them out of the really bad crises. So I think I'm really optimistic around JAK inhibition as sort of the nearest term. I think that in terms of natural remedies, I'm a huge fan of encouraging eating well and exercising and doing the right things to take care of your health. I haven't come across a specific diet or something that I think I would say like this is the thing to do, but I think that generally doing the things to stay well, I think are really important.
Yes.
Yes.
I was sort of struck by how there was, if you look at your own site profile, or your labs, it's always going to play with all the
Boom.
rapidly trigger. So I'm wondering if you sort of digital change, is there a positive feedback loop or a negative feedback loop that's missing? So people over the edge and things like that. So,
I think you're right. I think it's hard to, I think the clinical data really supports that, right? It's like sort of brewing, and then just explosion. And there's a patient right now in Florida who had that exact thing where he just sort of wasn't feeling well, telling his doctor's like, but your labs look good, your labs look good. He's like, but I feel off. And now a complete explosion, right? And so it does suggest that there's like, yeah, that maybe the brakes are, usually I think about in terms of like the brakes are off, or like, all of us, encounter inflammatory stimuli and we typically tend to move back into homeostasis, but it just seems like in calcium it just like spirals out of control.
Last question, Miley.
It's a great question. We've been, I think probably too simple-minded in the way we treat calciumins. If you fail any IL-6 blocker, we move to the next thing. If you fail any mTOR inhibitor, we sort of move to the next thing. But I think that I think we should be much more nuanced in thinking about that. And that, comments come up earlier as well. We haven't tried everolimus before. We decided to do sirolimus for the trial because there's a lot more long-term safety data. Ideally, we patients on this for a long time. I've been on it for 9 years. And so, the idea of a drug that's been around for decades as opposed to, about 1 decade was why we liked the idea of doing sirolimus. But I think it's safer and better in some ways.
David, thank
Yeah,
you.
thank you so
Thank you very
much.
much.
Yeah, thank you all so much.
Thank you all for coming. I'll put in a plug for a 3 p.m. symposium that actually will be right here. That has something to do with repurposing of drugs. Thank you all for coming.